After a patient with disseminated disease has a relapse and the decision is made to retreat that patient, the physician has multiple options. Depending on the duration of the first remission, retreatment with rituximab can be a reasonable option, especially if the patient had a long disease-free interval and or the patient is frail and considerations for other therapies may be considered too toxic. Patients who have a disease-free interval of under a year essentially should not be retreated with rituximab. Those patients will have a very unlikely chance that they will have a second response, and if they do, it's unlikely that it would be maintained. The considerations for second-line therapy are similar but differ somewhat from the considerations in the first-line setting. The physician has many things to choose from in terms of second-line therapy that is combined chemoimmunotherapy. The patient could receive rituximab bendamustine, rituximab CVP, R-CHOP, possibly fludarabine-based therapies. Currently, as of 2017, the option of ibrutinib is also an FDA-approved option. Ibrutinib is a continuous oral therapy, and unlike chemotherapy, has a better side effect profile. The treatment benefits about 88% of the patients if one takes into consideration complete responses, partial responses, and disease shrinkage. The vast majority of patients will not have a complete response, however, with ibrutinib therapy, and currently they will maintain treatment with once-a-day oral dosing until they either have disease progression or an adverse event that requires them to come off drug, or they simply don't want to take pills anymore.